Good evening, our dear viewers. Welcome again to Health and Lifestyle on E.N.T TV. Today we have a special guest with us. He is a colleague and friend. He is called Dr. Joseph Chiwanuka. He is an anesthesiologist and he'll explain what that means. As always, I am Victoria and we have Doreen again.
Good evening, everyone.
You're welcome.
Good evening, everyone.
So today we decided to talk about anesthesia. If you've ever had surgery, big procedure, small procedure, you have had some kind of anesthesia. And Dr. Chiwanuka is our in-house anesthesiologist. He is with us when we are doing surgery. We have talked about surgeries, we have talked about procedures, we have talked about, yes, they will put you to sleep, but we do not know what that putting to sleep is like. We do not know how you prepare for it. We do not know what to expect when we are going in for surgery and anesthesia. And today we hope we can answer some of those questions. So we hope Dr. Chiwanuka can answer some of those questions.
We are going to
not
questions.
us. We're going to fire away and he'll answer the questions. So without wasting any time, I'm going to let him introduce himself a little bit better than I have. And then we shall start off with our questions.
Thanks very much, Victoria. My name, as previously stated, is Joseph Chiwanuka. I am an anesthesiologist working with Atlas and training with Mbarara University of Science and Technology.
Before you even go any further, that word, anesthesiologist, anesthesiology, and logistics, it has all sorts of terms. Everyone calls it what they want. Our lay people, sometimes they say omukabisa or akalifomu. There's all sorts of names. But who is an anesthesiologist? Who is an anesthetist? Who is an anesthetic officer? We use so many different terms. Is there a difference really?
Well, generally we call them anesthesia providers because we have different categories, and it really depends on which school of thought you fall into. The Americans tend to have anesthesiologists and nurse anesthetists. But well, when we look at anesthesia providers, we categorize them into physician anesthesia providers and non-physician anesthesia providers.
So they may be a doctor or they may not be a doctor, but trained to provide anesthesia. Ah, I see.
So the doctor who has then trained in anesthesia is going to be called an anesthesiologist if you're American. The British don't actually separate them. They'll call them anesthetists. Then those who are not medical doctors trained in anesthesia provision in Uganda here are going to be the anesthetic officers, and now we have a category called the assistant anesthetic officer. The anesthetic officer, based on the new guidelines that are currently being presented in Parliament, is the one with a Bachelor of Science in Anesthesia. And then those with a diploma are going to be the assistant anesthetic officers. But we still, in peripheries, we still have those who are trained on job.
So should I worry who is going to do my anesthesia?
It is dependent on a number of factors.
Okay, and we'll start with what is anesthesia.
Before we
go to who's giving it to me.
Before we're giving it to you. Yeah. So anesthesia basically it came from the Greek term, and it just simply means without feeling, without sensation. That's the fancy term.
Kabisa.
No, well, it is very difficult to actually explain in our local languages. Like we previously discussed, it's difficult to explain to my grandmother what I exactly do.
Yeah.
But they associate it with dying for a bit of time.
And
so but hopefully this is something that helps us understand. So during an operation, we expect that you are going to feel pain or discomfort depending on what kind of operation you're having. So the anesthesiologist or anesthesia provider is there to make sure you don't feel pain, to make sure that your body is working as well and as close to normal as possible, so that we have good outcomes. Okay, and they also make sure that the surgeon is having the right conditions so that they can actually they can do the operation comfortably. So we are enablers for the surgery.
Are you supposed to make sure I don't remember anything about the procedure?
Yeah.
Now, that is going to depend on what kind of procedure. And when we are talking to the patient at the time, we are going to discuss exactly. So for our purposes, again, for the kind of operations that we do here, quite a number of them require that we make you, I will say, sleep. Okay, but it is deeper than the sleep. It's not like the sleep you had last night or that you'll have today.
So I think she's asking a very relevant question, because we say we are going to make you sleep. We'll make your child sleep completely. But when we sleep, we dream.
Yes.
When we sleep, if something bangs, you will. If someone touches you, you will feel it.
Yes.
So you're eliminating all that from my sleep.
We're actually taking you deeper than the sleep, so that you are not aware of what is happening. Sometimes we are taking over certain functions of your body, like breathing, and we use the tools that we have and the machines that we have to make sure that you're breathing fine, that your body is working fine.
So it's no wonder people think it's dying, because the only thing deeper than sleep is death. Well, no response, nothing is going on. So it makes a lot of sense. Like when you're trying to explain to someone and you tell them, so this is what is going to happen, and usually the question is, I'm going to die.
Like everything is going to stop for a moment.
I am not going to function.
In our minds, we think my heart will stop, my breathing stops. Basically, like you said, you're regulating so much, including you could take over my breathing for me.
Yes.
And I think that is scary, because it makes me wonder. Sometimes I come in and it's a very small procedure, right?
Yes.
We remove small little holes from the ear,
Yes.
from adults and children. And I'm wondering, do I really need to sleep? Henry here just said he has never had surgery. But he says the small procedure he has, in his opinion, was not an operation. Though he didn't feel anything because he watched everything. And I'm sure even mothers will say the same when they deliver sometimes.
Yes.
So the question is, are there different types of anesthesia? Do I always have to go into that deep sleep?
No, you don't always have to go into the deep sleep. So there are a number of things that we consider when we are going to choose the type of anesthesia for you. But first, the types. One is the deep sleep. That one we call general anesthesia.
Okay.
Okay. Where you are out. We don't expect you to actually feel anything, because we've given you medicine to make you go into a very, very deep sleep. We've given you something for pain, okay? And sometimes you are going to be taking over the body functions, some of the body functions like we stated earlier.
Okay.
Then we have what we call regional anesthesia, where it is just a part of your body that we are going to inject with some medicine, so that it does not feel. You could be aware, or you could choose to get some medicine that just gives you a bit of sleep like the one you had last night. But it is that region, because they are operating there, we are going to basically knock it off.
So you're putting to sleep one part?
One part of your body. Okay. Like say the mothers who are having birth, where we just get maybe the lower part of the body and we are knocking that one off. Okay, so they are not feeling that part of the body. Okay, and then sometimes, like you say, those small holes on the ear, that is local anesthesia. We are injecting around that part. Or when you're having a circumcision and they're injecting around, and it is, so they are taking away the pain. Sometimes you don't feel that part, or you may feel touch without feeling the pain. So those would broadly be the categories.
You feel the tugging.
Yeah, you could feel
I've had a C-section.
Yeah. So
I know the sensation. It's a bit strange and comforting at the same time, because you're being cut open but you don't feel anything, but you're aware that something is going
something
on.
is happening.
Exactly.
Yeah.
Yes.
Okay.
So probably that.
Is it, you talked about the mothers, and I've had this question from a friend before. She asked, why do they have to kill from here to the feet? The feet are not giving birth. Why can't it just be in the midsection? Why do you have to go all the way down to the feet?
So anesthesia has evolved over time.
Like all medicine.
Yes. Well, for the historians, you'd have to look back to 1846 to actually know when we first demonstrated anesthesia in the public. And at that point, everyone went to sleep for anesthesia, except the people who had laughing gas. There is a certain medicine that for the layman it would be laughing gas. But it wasn't very, very good at enabling a lot of the complicated operations. And along the way, we've come to develop both medicines and techniques that allow us to do that. So, for the mother who is giving birth, the technique that we are using cannot just put that section from just the tummy where you're going to operate down to sleep. It will end up involving the lower part of the legs, because where we are putting it, it is still difficult to control, so that it just remains in that section. So hopefully, maybe 100 years from now, we shall be able to do that.
No, so if it was like a plumbing system, you're at the main, eh?
Yes, but he just said that it's hard to control and stop it from going to the other systems. Now I'm worried. When you talk about that, could you have come in with the intention of blocking off my ear and somehow you end up blocking off my entire head? Or like, does it, instead of going down, end up going up?
Well, that is a very interesting question and a very relevant one. The discipline of anesthesia, like the anesthesia provider, they should be present with you throughout an operation, because anything can go wrong. We could start by intending to just block off just a small part of your body or the ear, and we end up with we get issues or complications that may require for us to take over the entire body. So that's why we have to be vigilant, and we keep monitoring you throughout.
So how do you know something might be going wrong?
We keep monitoring throughout. Okay. So during an operation, you are going to come in, we are going to put different, we are going to connect you to what we term a monitor. Okay?
My friend's child said they've put him on charger.
Well, I don't know.
Too many wires a charger. If you think about
so many wires going into so many different sockets.
If you think about it loosely, it kind of is a charger, because it's a life support at that time. Because everything is...
Well, whereas we are not putting electricity into it, we actually, sometimes we are detecting electric current, say from the heart. And I would just like to use this as an example of what you would see on a monitor. You know, I was once asked by a patient, do you understand what that thing is writing? Okay? So up here is something that is looking at how the heart is working.
That's
how
the
electricity, yes, the green, is looking at how the electricity goes through your heart. Because the anesthetic or the drugs that we give could affect it, but even some abnormalities of the heart would actually also affect it. Then the yellow here, well, these colors have nothing to do with the politics of the country.
I'm starting to wonder.
Important disclaimer.
The yellow here, and that 98% tells us how much oxygen you are having within your blood, because it is very important that oxygen gets to the rest of your body throughout your surgery and even after the surgery. Then the red over here, particularly this one here, well, is showing you how much pressure the heart is using to pump blood across.
So that's my blood pressure?
This number is the blood pressure, but in here, this is a monitor that we sometimes use, depending on the complexity of surgery, when we are looking at how, if for every beat.
The fluctuation.
Okay? Yes, the fluctuation. So that would be the intra-arterial blood pressure. But sometimes, or most commonly, we are just putting something on your arm, and it keeps compressing and releasing at a minimum of about once every 5 minutes, sometimes more frequently. Okay, and then over here, the next one is how much carbon dioxide is getting out, okay, from every breath, okay, and we keep measuring each of those. Then the next one, your respiratory rate, that figure of 14. And
how fast I'm breathing.
Yes, how fast you are breathing, okay. And then the last one is to make sure that you have the right temperature. For some surgeries, we may want to make you cooler than what is normal, but usually we'd want to keep you within the normal body.
Technology,
Yes.
I'll say.
Okay. So this is a basic. There are other monitors, but the most important monitor is the anesthesia provider, because they have to make sense and react and respond to what is happening.
So basically, even if you have that and you can't interpret it and it's making all this noise,
then you are in a dangerous place.
So your anesthesia provider has to be vigilant.
It has to be vigilant,
Well
has to be
educated.
present,
And present.
and not on social media.
Well, yeah, there's that. And with a newspaper and a coffee in hand. I mean, the cartoons everywhere.
So you've mentioned sometimes there are diseases or there are issues with your heart or whatever. What are some of those things that, and then you also talked about the types of anesthesia. So what conditions might I have that routinely maybe I'm supposed to have the general one, but I can't have it? Are there alternatives? What things are very important for me to tell you as an anesthesiologist? Okay.
As a patient?
As a patient. If I'm a patient and I know I'm going to have a procedure, what should I really tell my anesthesiologist?
When the anesthesiologist or anesthesia provider should come and have a chat with you. And we do not want to dictate exactly what we are going to do with you or what kind of surgery. The patient actually does have a role in deciding.
I can get to choose what happens to me.
An informed decision. So
this is new. Usually they wheel us in.
You go in and they tell you
you're going to sleep.
And you say,
yes, whereas
God, you know all my issues.
Whereas they are going to make you sleep or put you in the deep sleep, they should be telling you as to why that is the best choice for you.
Okay. That's, I think, an important thing for us to remember and to discuss with our patients, because many times we'll just say you'll get anesthesia, we assume it will be general as usual, but it's good to know that they actually can ask for an alternative where available.
Yes, where available. So if we are operating, it depends on how complicated the operation is and which part of the body that operation is happening. Because sometimes, yes, you may not have an alternative, but they should be able to explain to you why there is no alternative. So the times of doctor knows best have really transitioned, because quite a number of people are also looking at Dr. Google.
Yes.
Okay.
Yes,
but when you are looking at Dr. Google, you need to discuss with someone so that they can actually explain more in depth.
Don't you get like a weird reaction to patients when you tell them, so you have a choice, and it's...
I think usually the common thing is, you are the doctor, you know choose the best thing for me.
Yes, that has happened a number of times. Okay? And
where they tell you, you tell me which one should I take.
Well, this is a partnership, and the biggest stakeholder is actually the patient.
True.
And it is best that the patient understands why we are choosing what we are choosing, and we also look at the complications so that they are manageable. So earlier on you asked, what should I tell my doctor when I'm the patient? And the anesthesiologist should be able to review your entire health history because it has an impact.
Now you're looking at my 96-year-old grandmother.
Yeah.
Yes.
When you say health history, where are we starting? Is it a health history regarding the reason I am having the operation? Or is it
Since I was born?
I can remember.
Well, as much as possible, and especially because there are certain things that happen when you're much younger, but are going to have an impact on the way the anesthesia is conducted.
Okay.
Okay. Sometimes someone, well, it may not be relevant at the time, but someone smoked for 50 years.
Oh, so even if I smoked and stopped, it's important that
It's
you know.
important that you actually tell us
Okay. Anything else?
that I smoked for 50 years and I stopped.
Alcohol?
Alcohol is very relevant.
How fuck.
How far
I had a glass last night.
Yes, even when you had the glass last
Have a
night.
glass of
Okay,
wine.
because they are going to, we are going to be asked how much you take and how frequently.
Okay.
Okay, because we are going to, it has an effect on the way your body functions and the speed at which a lot of these drugs go out of the body. But on top of that, I mean, if you had a glass at lunch and then you end up coming for an operation at 3 p.m., there is also an impact of that. We may have to reduce the dose, or
Because I'm already gone.
because you already gone somewhere. So
Halfway there.
all these things actually do have an impact. So you need to review as well. You should be ready with as many of these things as possible. Sometimes you think it's not relevant, but it's extremely relevant. The fact that you actually had a heart condition, but or you think it was properly managed or has been managed, or you've been skipping medication, all that becomes very relevant as because it is for the safety of the patient at that point.
You've talked about medication. There are things we don't consider medication per se, and I think we experienced this a lot during COVID.
Yes.
There's a lot of herbs, bishaka, that we are taking. There's a lot of home concoctions.
Mhm.
Right now, every kid has cough and flu, and many
Oh,
parents have
boy.
given up on the antibiotics, thankfully. But we are giving a concoction of garlic and
Pepper, lemon, ginger,
and
children.
just something to, I think
honey.
we are giving vitamin C and trying to boost immunity. Is that important information for you?
Yes, it is very relevant information.
But it's not medicine.
You may not consider it medicine, but it is actually has an effect because you are taking it for a reason.
Oh.
And you're taking it regularly?
Example. Yes, there are people who have put, they are taking their medicine, the garlic, as because it has thousands of things it prevents.
Yes.
But it actually gives you a risk factor that you are going to bleed a little bit more compared to someone who is not regularly taking the garlic. So there are a lot of things that even supplements that people are taking. Please
Even
carry them so that we
people are
actually
juicing
yes.
a lot lately.
Yeah.
So there are a lot of things that we are using for health benefits that we've read off the internet. But it's very relevant that your anesthesia provider and even your doctor who is going to have the surgery, who is going to do the surgery, that they actually do get to know.
Other than what people might be taking, some people may not be taking certain things. Like recently I was on a diet to lose weight. I'm not ashamed to say that. And it's so I was doing intermittent fasting.
Yes.
And it depends. You can fast for 16 hours a day, 18 hours a day, 20 hours a day, and then eat in the remaining hours. Is that important?
Yes.
If someone is on any kind of diet, and not necessarily that they're taking in a lot of supplements, but they're on a diet.
It is, they're doing it for a reason, and it is health.
Yes.
And I've said you need to actually talk about your health with the anesthetist. Being very fat and getting into the obese end of fat is not a very good state to be in. So it's good when people start losing weight, but even the people who've lost excess weight are also carry certain risks.
You really can't win with this one, yeah?
No.
There's too healthy, then there's too unhealthy.
Very unhealthy.
No, well, when we talk about
Health is health.
malnutrition,
Yeah.
malnutrition has two ends, okay? And there is being below one's weight, or
So
expected
you could
weight,
be underweight,
Underweight.
and then you could be
overweight.
Mm-hmm.
Obese. So we tend to think that malnutrition is underweight. No, there is also the other spectrum. But based on one's diet, okay, it is also relevant because there are also certain tests that would want to see because your body is working differently and trying to factor in at what point you're having the surgery. There are going to be some abnormalities. Because once you use up all the glucose that is within your body, then you are going to start using other things. Like
And
the
that's
fat.
the idea
And
of
that's going
fasting.
to affect
Yeah.
the way that your body is functioning. So your anesthetist needs to know.
So if I can just give a bit of a summary, the key information I should tell my anesthesiologist is anything I've changed in my lifestyle,
Yes.
whether I've gained weight, lost weight, did I smoke, did I drink, how often, what do I drink, what do I smoke, what do I eat at home.
Yes.
So
Regular diet.
yes,
yeah.
regular diet. You've talked about
Medication.
medications.
Medications that you're on. So earlier on we talked about the herbal.
Yeah.
But we also need to look at what would be
medication.
what you've picked from the
Our
pharmacy.
Western drugs,
Yes.
like we call them.
I don't
So
know
what you were on in the recent past and what you're
and
on
what you're
currently.
currently on,
Okay.
because it has an effect on how the anesthesia is going to be conducted.
I'm going to ask you a very tricky question.
Yes.
Many a times we have had patients, and then sometimes as doctors, we walk in and they ask you, how old are you? Today I'm feeling 16. And I say I'm 16. But in truth, I'm probably 28. Is it important? I mean, there are things we take lightly.
Yes.
Like I could just shave off a few years from my age. Does that in any way, form and shape affect you?
It does have effect.
You just want too much truth.
No, we need to know everything so that we actually do plan for you something that is safest for you and we get good outcomes.
I guess where I'm coming from, is it going to be different when we are dealing with, in your field, when you're dealing with different age groups?
Yes.
Extremes of age. We operate a lot of children, and then sometimes we do have
Elderly.
very elderly people. Some are healthy, some are not very healthy.
True.
And then we have the youth,
The normal.
Henry inclusive, who we assume is very healthy, exercises, eats well. Does me, you knowing my right age, influence what you might or might not do?
Yes, it does influence. First, when we are talking about the extremes of age, we expect the body, as the body ages, there are differences in the way it functions, what we term the physiology.
Okay.
And it is very important for when you give us your age that we understand and explain to you exactly how your body is going to be dealing with say some of the medications we are giving you. When you come, well, the difference between a 20-year-old and a 28-year-old is not that. That's not a reason that you
Henry's
should come and
laughing.
tell
I
us.
think he disagrees.
In terms of the physiology, okay? But, well, the difference is not that big in the way they are going to what we call the physiological reserve. But when you compare an 80-year-old to a 60-year-old, then there is a very big difference.
Okay.
Okay? When you compare a 1-year-old to an 8-year-old, there are differences with the way their bodies are working. In terms of how they are going to deal with the stress of surgery, but also in terms of how they are going to deal with the elimination of the medications we are giving to achieve the anesthesia. So it's very important that you actually do tell us the correct age. But on top of that, when we are talking about physiological reserve, there is also need to understand how much exercise one does.
Dr.
I could
Victoria,
be 16, but my body is 30 years old.
Yes, because we've met some people who are 80 years going on to 60.
My
Because
friend
they are very,
says
very
she's
fit.
averse to exercise.
Reverse to exercise.
Are there times you're going to have to tell a patient, we need you to fast
Some
weight on this
exercise.
surgery? Let's assume it's not an emergency operation. Patient is
Yes.
not dying.
Mm.
Are there reasons you may say, from the things that we've told you, and you say you are not ready for surgery?
Yes.
The surgeons are ready.
Mm.
Patient is ready.
The hospital is ready.
The patient is ready mentally, but
Yes.
their body is actually.
So is
not
there
very
times
good.
when you're going to come in and say it's a no?
Yes, there are going to be times. I'm going to give an example. A colleague has previously told me they deal a lot with children, and some of them, because we are feeding them endlessly, and we had the COVID period, they've gained excess weight. Sometimes they'll go in and they're trying to find what we call IV access
Just with a cannula.
to put a cannula, but the child is so fat that it is actually healthy for them to first go and lose weight in order for us to be able
To
to
put a cannula?
Yes, and surgery maybe have to be postponed.
Eh?
Such a reason. But let's go back and also think about the adult who's gained so much weight. They are obese. It's not healthy, first of all, for that. But the stress that the body is going to face, it's best that they actually do something before. So sometimes we are going to think about, it's called prehabilitation,
Okay.
preparing you for surgery, but there are going to be certain steps that are going to be advised for you. Okay? Surgery is a very stressful period of time, and the more complicated the surgery, then the more stress you're going to have. So with prehabilitation, we are actually trying to boost the body to be able to handle
The stress.
the stress.
And probably to heal well as well.
Yes.
Yes, I was
If-
actually going to mention, sometimes people think as long as I get through the surgery
Yes.
and I come out alive, I'm okay. But I don't think we think about the recovery period and what actually happens during the operation. Because for many people, when you tell them you're going to have surgery, their first concern is, will I come out alive? When that has been established, they say, will the disease go away? And when you have answered those questions, you think, I'm good to go. But they are not thinking about, this is how surgery will go with you versus another person who is otherwise healthy, and this is how recovery will be like. So I'm actually very glad that we are talking about this, because sometimes you have a hard time convincing a patient that you're not ready, it's not an emergency, it doesn't need to happen now, it's surgery that needs to happen later, but these are things that we need to do. Maybe you need to lose weight, maybe you need to gain a little weight.
Yes,
Yes.
So you tell her, they look at you like, do you know how
I've just
hard I
worked
have
so hard
worked to
to
lose
get
this weight?
Yeah.
But you need to gain some weight.
But also in our field, especially when we're talking about the nose surgeries, where we say we are going to give you medication over the next 2 months
Yes.
before we even discuss you need the operation, but you're going to be on medication for 2 months because we need to be able to handle the tissues and they can heal
Yes.
well.
Yes.
So it's good to know that there are
So
reasons why.
Something,
Yeah.
because, well, today if you are a farmer, would want that you have your operation and as quickest as possible, you can go back to your duties. If your body is not prepared well, the prehabilitation that you are talking about, what's going to happen is that you are going to spend longer
And your livelihood is affected.
and your livelihood is affected. So we need to prepare the patient to be sure that they can actually handle the stress so that they can heal as quickly as possible. So hence sometimes they're going to prescribe exercise for you
I'm
or
going to
nutrition. Okay, so that will tell you, oh, now you need to
Nutrition
eat a
is a
little bit.
prescription.
Yes, it is.
Some eggs and porridge.
just don't give me that one. So maybe just as a segue into that, you're talking about when we say no, but I'm going to make the large assumption this is an operation that can wait.
Yes,
We have operations that
that cannot.
can't
Can't wait.
wait.
Yes.
And the patient
And I'm going to come in, yes, and I weigh 142 kilograms,
Okay.
but this cannot
Wait. So, hence the amount of risk that is associated with surgery. So, if an operation can wait, it allows us time to optimize your body,
minimize the risk.
to minimize the risks. If it cannot wait, then the risk is higher. So, for every patient that we see, there are ways of scoring them so that we know the risk category.
Okay. So you can
So
predict how
We
risky this might
have
be.
a rough prediction of what is going to, of the level of complication that can happen,
Okay.
and therefore we prepare for it. So that is, anesthesia has a lot to do with preparation so that we prevent things. Or if then those things do happen, we respond appropriately so that we don't get more and more complications.
So you need to anticipate them.
Yes.
So that in the event that they happen,
They happen.
usually when we are setting up for surgery, the surgeon is on this side and they're setting up, and these people are there preparing all kinds of things.
Exactly.
And I remember as a student, I would look at them and be like, do you need all that?
Oh yeah, I've been
And
asked by an
what-
attendant before.
And depending on the surgery, there are some surgeries where now they are going to spend about an hour preparing. But I think it's all for the reasons that you've mentioned. One, prevent risks, but also anticipate them so that if they happen,
We are
We
ready
are
to
ready.
we are
for-
ready to act
to act.
Yeah.
on it. So
Yes.
it's comforting to know.
Yeah, very true.
Yeah.
But
Very
I
comforting
suddenly
to
feel
know.
like we have the easy job.
Oh yeah.
Oh yeah, we have. I think we
The
have.
anesthetist is there. He's going to be your someone overseeing, your guardian angel.
Guardian angel.
Yeah.
It's not once or twice that they've got to step in and tell the surgeon what's happening.
Or first stop.
First stop, can we do something about what you are doing over there? Okay, because it is part of the team effort, and ultimately we want very, very good results. So your anesthetist is your advocate in there.
Is the patient's advocate.
He's a patient's advocate.
So they ought to be to see the
We
patient.
need to give you more
than-
respect
Oh, yeah.
than we do
Than
and
we
treat
do
you
for-
nicely.
Usually we just say blood pressure is too high.
Oh yeah.
Why am I bleeding a lot?
Why am I bleeding a lot? Oh, but even we see the effect of the bleeding and we've got to respond.
Anyway, so that put aside, we've talked about the things that you need to know about the patient. I, as the patient, or I bring in my little daughter, son, or whatever the case may be, are there things I should ask my anesthesiologist or my anesthetic
Questions,
provider?
maybe.
And this is just for anyone preparing for an operation, for you, for your loved one. And it may never be you that they meet, but are there things that, as a takeaway for me, that I should always remember to ask?
On Sunday I was asked by a patient, are you any good?
I hope you pulled out all your certificates, extra training.
Well, the patient was very grateful after she had the anesthesia.
So you were
Okay.
some good.
No, but well, it
Didn't
was.
disappoint.
We went through why she was asking about that, and it related to a patient, to a friend who
Okay.
didn't have very good outcomes. Okay, but like I said before, the patient is a partner in this whole process, and they play the most critical role
The biggest stakeholder.
in the outcomes, and yet they also have the biggest stake in.
This is about them.
Yes.
Yeah.
So they need to understand when we are talking about, say, prehabilitation, they're the ones going to do the prehabilitation. If I tell you now you need to add a bit of weight, you are the one going to go and eat the food.
Okay.
So you need to understand there is no question that is out of bounds for the patient or for the guardian in case you are dealing with a child.
So the patient should feel free to ask anything
They
on
should
their
ask
mind.
anything.
Are there things that are key to ask you, the anesthesia provider? Because I'm going to ask my surgeon, where are you going to pass? First question we always get asked for tonsillectomy.
Where are you cutting?
Where are you cutting? And for us, it's easy to walk through. No, you're not going to have any scar on your skin. Everything is going to be done within the mouth and whatnot.
Yes.
And at Atlas, we are lucky that we have you and another colleague that we work with. And usually we have you come in and have a chat with the parent or the patient.
Yes.
But many times they're so anxious about the operation that's coming. You're taking my child away from me.
Yes.
And sometimes they're wondering, why can't I come with you?
Yes.
And then I'm asking, are there things I should, in my mind, remember to ask about?
Yes. So one of the things that the anesthetist is going to have to explain to you is the procedure of what is going to happen.
So I have
Right.
the right to know what will
Yes.
happen.
And even if it is a child. So there are certain places where the parent will be allowed to go into the operating room with the child.
Okay.
Because it helps reduce the levels of anxiety. Although, once you are going in with the child, whereas yes, you are reducing the anxiety of the child, you should not become the next patient. You should not become, because then it creates a very big scenario where the anesthetist has to get between two patients.
Decide between his.
In case the mother passes out.
Surgery is the only place where the patient is the VIP and they actually have a team around them, all working for the patient's benefit. Because you'll have the surgeon, you'll have the anesthetist, you'll have nurses in there. It's a big team, depending on the complexity of surgery. So as you go in with the child, they should explain to you, we are going to either give the medicine through the cannula, so that the child sleeps abruptly, or they are going to inhale the medicine and at some point you are going to see them fighting and it is normal, or if they do not cooperate, we may have to use a bit of force in order for us to make them sleep.
What do you mean by force?
It's more of restraining them, because once the child is not cooperating, and the parent is not actually going to be able to help out with that process, then sometimes we may have to restrain the child as they try to breathe this.
Okay.
So we need to just understand the whole procedure and the whole process. Sometimes we are going to discuss about the medications that you've received before, because the way you may have allergies or reactions or anaphylaxis, and that could create problems. So when you tell us that, then we could avoid some of them.
Okay.
But on top of that, some people have come out of the operating room and they are yelling, they are having different dreams and it is important that we actually explain some of those things and we see how to avoid them, because there are ways of trying to avoid that.
So what I'm hearing is I should ask you about what you're going to do.
Yes.
How it's going to go down.
Yes.
For the patient.
How I will wake up.
How I will wake up.
Yes.
What I should expect my patient to have, or how the patient is expected to feel, if you can predict, after the operation.
Yes.
Okay. Now, is
No
there
question
any
is out of
other...
bounds.
And any other question
Yes.
is, I think just as coming from a mother whose children have had surgery, it even coming from a medical point of view, it's nerve-wracking and you're very anxious, because as you said, you're handing over your child, and just like understanding what to anticipate, because they told me this is the drug we are going to give, he's going to wake up a little bit not happy and violently, and because you know all that is expected, you anticipate it. When it happens, you're not thrown off. You're not thinking there's something wrong. Sometimes parents hand over their children and then you're this side and you're hearing your baby crying. And it's distressing. Sometimes they will cry, sometimes because of so many people in the room, it gets very nerve-wracking, and just having an introduction to the different people. And so the other thing I wanted to say was, I think just having a conversation between the anesthesiologist, the surgeon, the patient, and just like have a meet and discuss and talk about all these things, talk about your anxieties. Like Dr. Joseph said, no question is out of bounds, no request is outrageous, because this is life.
Yes.
that we are dealing with. And so if you need to have a discussion with your surgeon, anesthesiologist, ask. Of course, if it's an emergency, it might be a
Then-
different situation.
Yes,
altogether.
depending on the degree of emergency.
Complexity.
Yes.
Yeah.
When should I last eat? When should I eat next? We've had patients starved post-surgery
And
Yes.
they don't eat.
and they don't eat for almost 48 hours, and you come and the patient is dying from low glucose and not really the operation.
What did you eat?
Okay, one of the
You,
biggest.
you keep telling us, don't feed after midnight.
No, we don't.
That was quick.
No, we do not. Okay, let's first. I think it's important to know why we are telling people not to eat a given number of hours before the surgery.
Okay. And what not to eat?
Yes. So let's look at well, as you breathe in, okay, your air is going through your nose, and well, there is a certain part where both the food and the air share a pathway.
Yes.
Okay. Then the food the air will go down to the lungs, but the food also will go down to the stomach. Now, some of the medicines we are going to give change some of these things in the way the food is controlled, so that as the stomach tries to contract, the food is not coming back up.
Okay.
If, as we make someone go down to sleep, or as we give anesthesia to this patient, there is a tendency that sometimes they're going to vomit. But the medicines we've given are also going to, you know, when you drink water and it goes down the wrong way, you start coughing. But now the medicines we give are going to take away that ability to cough. So that food could end up down in your lungs, and it gives you a very terrible reaction within the lungs. We call it a pneumonitis, because your stomach actually does have very, very strong acid. If it comes and goes into the lungs, it's just going to be burning the lungs.
So you're worried about me having eaten shortly before the operation,
Yes.
that I could
Yes.
vomit and things will go
And
the wrong
go
way. Then we
the
can't
wrong
breathe
way.
well.
Then you are going to, that is a very, very big complication. And it's not once or twice that it has actually led people to go into intensive care. And
Death.
ultimately death. So it is one of the ways of preventing. Now, what are the guidelines? It's not midnight.
For some reason, I haven't, and from medical school, it has always been
Stop eating at midnight.
At midnight. And patients always ask, so Chachiro,
Why eat at midnight? And when you say stop eating at midnight, if they routinely have supper at 9, they're going to have it at midnight. So that they are not hungry in the morning.
Okay, so the more fatty the food you are taking, the longer it spends in the stomach.
Okay.
Okay.
So if you've just had a meal, we assume every meal will have fat in it.
So I've just had my yeshabwe with kalo.
A shower with karo,
Why are you
odo,
attacking our meals?
odo with kaunga. You have to count off 6 hours before you can have an elective surgery.
Ah,
Okay. The less urgent the surgery, the more we have to stick to that guideline.
Okay.
But
And how about little kids?
yes, we can plan their surgery to fit within some of those. But ultimately, you can have water and water and water, and the latest guidelines will say you can have clear water up to 1 hour before going, because water goes through the system much quicker.
When can I stop having water with sugar?
1 hour before we start the surgery.
Is water with sugar equivalent to juice, soda,
Tea.
black tea, milk?
So what we want to, well, when we are saying 1 hour, we look at clear fluids, non-alcoholic.
Non-carbonated.
That's a very good disclaimer.
Is it? So
Okay.
soda is non-alcoholic.
Let's start with clear fluid.
So
That
Sprite.
is non-alcoholic.
Okay.
Okay?
So no Eugene.
So because if I say 1 hour, then someone is going to go and get their bottle of Uganda Waraji.
Oh, on 7, it's clear.
And what do you mean by clear? Because when we talk about juice, it depends on how people have prepared the juice. So some juice has particles in it.
Yes.
And those are going to be difficult to go through the system. So that particulate juice actually sticks to the 6-hour rule.
Okay.
Okay.
I know that there are times when splash was more readily available,
Yes.
and we would
Apple
tell
splash.
we'll tell the parent, give the
Yeah.
child an apple splash, a
Yes.
small carton of apple splash.
Yes.
And I think it comes to the reason because it's quite clear compared
It's not
to like
particulate
mango.
at all.
Mango is very thick.
Yes.
So yeah, I think that's helpful because parents worry when you have a long list and you're waiting and you last fed at 3 a.m. This is now coming to midday.
Yes.
Baby is wailing. I think it's a very good advancement in
Yeah,
this.
but maybe we should also blame the surgeon. So earlier on we said
It's never our fault.
it's never
usually
it's never
anesthesia.
no, because one of the key questions I keep getting from the patients is how long will the surgery take, or how long will I take to wake up,
Yes.
and who is the determinant of this?
You make them sleep so you wake them up.
Yes,
That's my answer.
but
to it.
we keep them we keep them down as long as the surgery is going on. So who is the determinant?
Okay, I'm going to say that I guess it's both of us. We all play a role in this.
Yeah.
Sometimes we walk in and we think we're going to do one thing,
Okay.
and it
And
becomes
then
more
the
complex.
plan changes. So sometimes you walk in thinking you're going to do something long,
And then,
And
and then
becomes
it
very
is
short.
shortened
And then the
because you
patient
get
will
in
say,
there and
"Did
you're
I
like,
do the right
oh,
Yes.
I didn't need to do all that.
But then
you
you've
know,
already put the patient to sleep because we planned
for
2
that
hours.
period of time.
So and then we take much
So-
longer to wake up. So
Hence the
yeah.
good when having the three-way conversation, surgeon,
Yeah.
patient, and anesthetist.
And we have to
So that-
explain that if we
yeah.
find this is what will happen. If we find this,
Yes.
this is what will happen. And another thing that I guess we haven't talked about is there's a conversation between your anesthesia provider and your surgeon
surgeon.
that has to happen.
Yes.
We have to talk about, okay, how long is this going to go? Okay, what's plan A, what's plan B, what's plan C? In the event that we change course of action, what do we do in that regard? And then we also look at, okay, this is a patient, this is a child, maybe she has this and these conditions, maybe we have allergies. So we put all those together when we have that discussion. And the discussion doesn't happen once, twice.
Yes.
It happens the day, sometimes it happens a week
Month-
before
sometimes
surgery,
months before.
the day before the surgery, the day of the surgery, during the surgery. Like we keep having back and forth, all because we want
The
the
best
best outcome for our patients.
Yes. And sometimes, well, the surgeon is going to say, this operation is going to take 2 hours. But like Victoria already said, sometimes preparing can take an hour.
Yes.
Okay.
Yeah.
But even there is a recovery period because there are still dangers as someone emerges from anesthesia.
Yes.
Okay. So we also keep monitoring those patients even after they've left the operating room, because we are trying to make sure that they are safe enough to actually go back and be with their loved ones.
So you're saying
So-
when they leave the table, the
Yes.
operating
So the
table,
operation
there's
could
another
take-
room on the side.
Yes. The operation could take 2 hours, but we are still monitoring them for a bit of time.
They receive the patient 4 hours later and they're thinking,
Operation
Yes,
took 4
that
hours.
the operation took 4 hours, but there is a whole process to it. So when the surgeon is telling you, oh, this is 2 hours, then the anesthetist should also tell you, well, I think preparation is going to be 30 minutes. We'll do the 2 hours the surgeon asked for.
And we need an extra hour or
we
so
may
after.
need an extra
For
hour
recovery.
or more.
Depending
No,
on how someone
maybe
recovers.
Yes.
maybe in relation to your point on conversations, you do meet the parents, the surgeons we meet. We talk about it even after the patient has gone to prepare, but you do meet the patient before the operation, sometimes way earlier to plan.
Yes.
Then you might meet them before the day of the operation. Do you ever have to come back and see them after the operation?
Yes.
Or you're one of those doctors that peep in and we never see you again?
No.
Okay.
We need to see, because what has happened can have complications. So a review is in order.
So
To
you
make sure
come
that
back
you're
and we
safe.
have a conversation
Yes,
again?
a conversation again. But the results, some of the operations well, just have discomfort. There are operations that come with a lot of pain.
Okay.
And I think your best advocate and person to treat your pain is your anesthetist. Okay? So when they come in, there are certain things they're going to be looking at, complications. That's when you may complain about the sore throat because they had a tube down your throat to help you breathe. They're going to work on that. If there is pain, they're going to come up and review the pain plan so that you actually have a good experience throughout. The perioperative period is filled with anxiety, but we are there to make it comfortable. Okay? So coming and planning with you and telling you about the pain management and what will be going on, and then your plan, because not you could plan and something is different, or you may need to reduce, you may need to increase certain medications, you may need to add something. So all that comes under the auspice of the anesthesia provider.
This has been a very great and enlightening chat, and I'm thinking I know more now. I have had surgery before. I feel like I should go back and first ask the questions I should have asked at that time. Unfortunately, it couldn't have waited at the time. Dr. Chiwanuka, last point. If you were to see a patient at Atlas today and they're going in for surgery, usually our surgeries are elective. We don't have a lot of emergencies.
Just a few.
Occasionally, we have emergencies that we're going for. Okay, so emergency or elective surgery, or Dr. Victoria has brought her child. What is the takeaway for any parent or the attendant of a patient who is going to have surgery from you as anesthesia?
The key thing they need to know is that, one, there is an anesthesia provider who is going to care for them.
So they are safe.
They are safe. They need to discuss what is going to happen before, during, and after. Sometimes you could ask for an extra test.
Yeah.
To just make sure that what we are going for, we understand. Best if we have a three-way conversation, so that we actually do understand. And the best, or what we are aiming at, is for the biggest stakeholder in this to be a partner in their process of.
So we encourage them to participate.
To participate
in their care.
Yes, the patient is the partner. Who is a partner in this, and we are all working together for the biggest benefit to the patient.
I think my take home from this was, no question is outrageous.
Yeah,
No.
just ask.
Just ask, raise your concern, whatever it is that comes up in your mind. If it is enough that it is bothering you, put it out there. It's for us to deal with.
Okay.
Thank you very much.
Thank you very much. We hope this has enlightened you. We hope you have learned a thing or two. We hope you are now a bit more comfortable considering surgery, especially if you really need to have it. And we hope that you will not be afraid to ask those questions. Here at Atlas Audio and Medical, we encourage you to always take part in your care. Ask as much as you need to so that you can understand.
I'm going to say, if they have questions, feel free to send them in.
Please,
we
feel free to
definitely
send
can
them
have
in.
him back if it's necessary. And hopefully with your questions, some of the things we asked today are things that you ask us when we have a chat about surgery.
Yes.
More often than not, here when we discuss the operation, you might meet with him or our other providers on the day of the operation. It's rare that we will meet with him before the operation, but usually we do. And sometimes things get lost in translation and questions don't get asked. But if you've had an experience before you would like to ask about, our numbers are usually available. You can just send us a message and we will transfer the questions and probably have them answered for you.
Thank you, Dr. Chiwanuka, for your time.
Thank you too.
Much appreciated. Good evening, everyone, and thank you for watching.